Hello and welcome to WSPHA's March webinar, Health Equity, Are We Making Progress Yet? We're happy you are able to join us today. Before we get started, I'd like to go over a few technical details with the attendees. First off, as the first screen shows you, to obtain the best audio and visual quality, please exit from all other applications which can hinder the webinar transmittal. Secondly, you should see a control panel on your screen, and the grab tag to the left allows for different options. The arrow will allow you to open or close the control panel. The square will allow you to view the full screen. And then there's an audio pane and a question pane. In the audio pane, you can change whether you're connected to the webinar via your computer or via telephone. And if you have issues with audio and you're connected with your computer, I suggest that you switch to the telephone, which you can do during the webinar, and all of the information for doing so is in the audio pane. Finally, due to the large number of attendees today, we will be accepting questions through the question panel only. We will not be doing live questions. So if you have questions for the presenters that come up during their presentations, please submit the questions through the questions pane, and I will be monitoring them, and then we will pose questions to the presenters at the end of the session. I believe that's it. So Sabrina Chambers will now do the introductions.
Good afternoon and welcome. Just another note, today's session will be recorded and everyone who is registered will have access to a PDF version of the slides on the WSPH website. My name is Sabrina Chambers. I am the Assistant Division Director for the Tacoma-Pierce County Health Department Strengthening Families Division. I will be your moderator for this afternoon's presentation. As the moderator, I will be responsible for monitoring the time for the four speakers who have 20 minutes each, including questions. Our first presenter is Marilyn Sittker. She has a master's in public health. She's the lead epidemiologist of the Chronic Disease Prevention Unit at Washington State Department of Health. She was responsible for needs assessment, monitoring, and evaluating the programs to address chronic disease and their risk factors. Yeah, we're having a little difficulty, Marilyn. We'll put your slides up in just one moment.
Super.
Isn't technology grand? Having difficulties pulling up the presentation.
Go ahead.
Yeah. Marilyn, do you want to go ahead and start, and then we can catch up with you?
Sure.
Okay, we're good.
Okay,
Go ahead, Marilyn.
Thank you so much, and thanks to everybody who is present on the webinar. Well, John Britt contacted me about a month ago, and he said, Marilyn, we're having this wonderful panel discussion of health equity, and could you present a comprehensive, fun overview of all the latest developments in the data about health equity, and can you do it in 15 minutes and make it really lively? And I said, well, I think I can do some of that. I don't know if I can do all of that. So actually today we are going to focus mainly on chronic diseases and their risk factors, and we're only going to take a handful of them so that this will be an easily digestible presentation. And as we get started, I want to acknowledge my colleague, Dr. Dennis McDermott, who performed most of these analyses. Next slide, please. Like a number of other departments in the Department of Health, the Chronic Disease Prevention Unit within the Community Wellness and Prevention Office has been investigating ways to measure disparities in chronic diseases and their risk factors for the last several years. And it's especially timely to review these data because we've recently been introduced to the Agenda for Change, Reshaping Government Health, Reshaping Governmental Public Health, which features health disparities heavily and places an emphasis on getting quality and timely data to monitor progress. And in addition, just a couple months ago, MMWR came out with a supplement on health disparities and inequalities. Now, I'm going to mention that usually in our analyses, we are used to seeing risk behaviors and health outcomes analyzed according to social position as measured by income, education, and race ethnicity. But we know that the things that are driving, the social determinants that are driving these health disparities are very complex. And oftentimes it's helpful for us to have a framework or a model to help us understand what's driving these things. So on the next slide, please, we're going to see the World Health Organization model. Now, this looks like a bit of a complicated model, but I'm going to just point out a few things, and you're welcome to go and delve into this model at your leisure if you wish to do so later. We need to recognize, first of all, that social position, that the way that we usually see it measured by income, education, race, ethnicity, etc., those are just markers for social position, where people are in the social hierarchy. It's often interesting to think about what puts people at those different positions on the social hierarchy in the first place. And if you look at the far left, you'll notice that the World Health Organization model acknowledges that there is a socioeconomic and political context that drives where people get pigeonholed and what keeps them in those pigeonholed. It governs their access to things like education and job opportunities, which enable them to participate fully in the life of society. So some of those things in the contextual factors include our governance, our macroeconomic policies, public policies governing education, health, and social protections, our labor market, our housing, our land use, etc. These things in the model are considered to be structural components driving health inequalities. We recognize that access to things like education, wealth, occupation, income, those things in turn govern the material circumstances of our lives, such as where we live, where we work, what kind of jobs we have. We also recognize that our social position influences our behaviors and even our biological factors, such as the amount of stress that influences cortisol and other stress-related hormones that have an impact on our health, and that there are also mental health or psychosocial factors, and that all three of these things have interdependence and interrelationship. We consider those to be intermediary determinants of health that then lead to having an impact on the far right on equity in health and well-being. And it's important to note that whereas we in public health have gotten much better at looking at the connection between social position and health outcomes, we still struggle to document and look at the relationship between social position, those intermediary social determinants of health, and then the health outcomes. So next slide, please. So what I'm really going to talk about today, having gone through that lengthy explanation, is really answering some fairly simple and basic questions. We're looking for this presentation at the chronic disease diabetes and associated factors such as tobacco use, obesity, and hypertension. And for these conditions, we wanted to know how big are the current disparities, how have disparities changed over time, and how many people are affected. And we looked at BRFIS data, Behavioral Risk Factor Surveillance System data for Washington, to answer these by education, income, and race ethnicity. Next slide, please. So we're going to start out by looking at current disparities. And you can see we've got the four conditions. We are using an income measure, percent federal poverty level, where 100% federal poverty represents the poorest group, and that's equivalent to about $10,000 per person or about $22,000 for a family of four. This lowest level is shown at the far left of the graph. There's a couple things that I want to point out here. First of all, for each condition, we see that there is a disparity, a difference between the lowest and the highest group. We have a couple different patterns going on. For obesity and diabetes, we see there's sort of a stair-step pattern from the lowest to the highest income group in terms of the magnitude of the risk factor. For smoking and hypertension, we see more of a threshold effect where the two lowest income groups have roughly equivalent prevalence, and the highest income group has much lower prevalence. Another thing that I'd like to point out is that these conditions all have different orders of magnitude, ranging from diabetes, where the state average is about 8%, all the way up to hypertension and obesity, where we've got 26%. And that poses a bit of a challenge for us when we're really trying to compare how much disparity there is between conditions. We need to find a way to overcome the fact that there is actually a difference in the magnitude, and we're going to talk a little bit about that on the next slide. There's a couple simple ways. Next slide, please. A couple simple ways that we have of looking at this, and I'm sure most of you are familiar with this. We can use some absolute measures or relative measures. So we can look at just the arithmetic difference between the prevalence for the wealthiest group compared to the least wealthy group, and just take a simple difference in those percents, which for this example for diabetes is about 6%. Or we can look at the ratio of the highest prevalence to the lowest, 11% divided by 5%, and that comes out to be a risk ratio of 2.2. Next slide, please. We can see then for our four conditions, and you can see we've got the statewide prevalence for each one. If you look, and can you click on the slide? Can you advance the slide? Okay. If you were to look at absolute difference, you'd say, well, obesity and smoking have the biggest disparity. If you were to look at relative difference, click again, you would think that diabetes and smoking have the biggest disparity. And click again, please. And then one more click, and we can talk a little bit about the difference between these two. Both of these are very useful measures. Absolute difference describes the gap between richest and poorest in terms of percentage points, and it can be translated into the number of excess cases we have, unnecessary cases. We can also look at relative difference, and that helps us compare health conditions that have different orders of magnitude. Okay, let's move on to the next slide and start looking at trends and disparities by level of educational attainment. Here we're looking at obesity, and we're looking at this by education measured at three levels: high school or less, some college, and college graduate. All of these groups have a similar trend in that they're all increasing in obesity over time. But you can see that the two lowest educational groups are increasing at a much quicker rate compared to the best educated group. The lines are diverging, and this means that disparities are growing over time. I like to say this looks like an alligator opening its mouth. Another thing I'd like you to notice is that there is this threshold effect where the two lowest education levels are grouped together. And let's move to the next slide and take a look at diabetes, see how that compares. Note for diabetes, once again, we've got this threshold effect. We see an increase in diabetes for all three groups over time. However, these lines look a little bit more parallel to each other. So we don't see growing disparity over time. We see that the disparity is relatively constant. Next slide, please. For hypertension, once again, we see this threshold effect, and it's a little bit difficult to see, but actually there is a little bit of a growing gap over time. So the alligator is opening his mouth, but only a little bit. Next slide, please. When we get to smoking, first thing you're going to notice is that instead of seeing the stair-step effect, instead of seeing the threshold effect, we do see a stair-step effect. We see that these three groups are widely spread apart in their prevalence, and they've kind of maintained their distance over time. We do see that all of these groups have declining rates of smoking, which is one of public health's big success stories. But if you compare the slopes, which is just a measure of how fast things are decreasing, you see that the best educated group is decreasing at a much quicker pace than the lowest educated group. So let's move on to the question of how many people are affected. Now, I know this looks like a lot of math, but I'm going to walk you through it, and it's going to be not painful, I promise. In the first column, you can see our education groups. Second column, you can see the prevalence of obesity for adults age 25 and older for the most recent period. And we're noting that threshold effect for the two lower groups. You see the state population in the third column, and I'd like you to note that this is how many people in our state are in these three different education groups. They're roughly equivalent. We've got about a third of the adult population in each one of these educational categories. We can multiply the number of people in each group by the prevalence to come up with the estimated number of people in each group who are obese. And that is the fourth column we have there. Now, moving on to the fifth column, we can say, well, okay, how many people do we estimate would be obese if they had the same prevalence of obesity as the best educated group, that 21%? You can see that this number is much lower than the number in the previous column. By simple subtraction, we can then determine the number of excess cases. This would be for obesity a total of about 330,000 number of people who are obese simply because they are in these two lower educational groups. They are unnecessary cases. They're cases that could be avoided if we had more equity in our society. Let's move on to the clicking to see. Same calculation for diabetes, smoking, hypertension, and you can see that the number of excess cases ranges from about 100,000 for diabetes on up to nearly 500,000 for smoking. Moving on to the next slide, I just want to give you a little taste of our exploration into that mysterious category of looking at the material circumstances of life. A few years ago, we partnered with our tobacco program and our STEPS program to do a study which asked people what kind of amenities they had to help them be physically active in their neighborhood. And we analyzed the results according to their educational attainment. We found out that those with more education were more likely to live near a park, playground, school, or trail. They were more likely to use those amenities. And as a result, they were more likely to get enough physical activity at the recommended levels. And there are all kinds of caveats we could put with these data. These were self-report data, but it is confirming what more rigorous longitudinal studies have demonstrated. All right, now let's take a look at disparities by race ethnicity. Next slide, please. A couple things I would like to remind us of. While some racial ethnic groups are disproportionately lower income and education, we want to remember that disparities by race ethnicity are fueled by more than just income and education alone. For example, the stress associated with discrimination and racism affects biologic and behavioral factors, which, as we know, leads to more chronic diseases. Another thing that we want to note is that unlike the educational groups we looked at earlier, various racial ethnic groups comprise different shares of the population. The biggest population group is non-Hispanic whites. And I do want to point out, just for those of you who are unfamiliar with this category, we have split out the old category of Asian Pacific Islanders into Asians and Native Hawaiian or other Pacific Islanders. That's that NHOPI group up at the top. We did find that that group is very different culturally and in terms of their health outcomes compared to Asians. So when we talk about disproportionality, what we mean is if a group comprises, let's say, 6% of the population and yet has 20% or 10% of the disease share, we say that we have disproportionate, they have a disproportionate share of the condition. let's move on to, oh, and another point I wanted to make is that there's no inherent ranking, unlike education or income where you can say one is the highest going down to the lowest level. You can't rank order these racial ethnic groups because they're just categories. They're not inherently one better than the other. So I want to summarize our current data for these 4 conditions by pointing out that American Indian, Alaska Native, and Black have a higher prevalence of all 4 conditions compared to the state average. Asians have a lower prevalence of obesity, hypertension, and smoking compared to the state average. And Hispanics have a higher prevalence, oh, previous slide please. They have a higher prevalence of diabetes and obesity, but a lower prevalence of hypertension and smoking compared to the state average. And that NHOPI or Native Hawaiian, other Pacific Islanders have higher prevalence of obesity and hypertension compared to the state average. Okay, now we can go to the next slide. And here we go. And we're going to note, for brevity, for time's sake, I'm only going to show you 2 conditions. First thing I want you to note is that these trends for obesity and race, for obesity and diabetes by race ethnicity over time, it really looks like a bunch of spaghetti thrown up against the wall. I mean, it's a lot of data because we have a number of years of data. We're looking at 5 different racial ethnic groups, and we're looking at 2 conditions. So I'm not going to go into these in a great deal of detail, but I want to point out a few highlights. If we look at the slide on the right, diabetes by race ethnicity, I want to point out that this black dotted line toward the bottom of the slide is the, oh, and thank you for pointing that out. That is the state average. And you can see that right below that there's sort of a fat, caterpillar-y looking grayish line, and that is the non-Hispanic white population. And it's kind of not surprising. It's hugging that state average because it comprises one of the largest groups, so it heavily influences the state average. You can see that all of the other lines for all the other non-white groups are above the state average, and they're all increasing. They're all increasing over time. For this reason, we can say that there's growing disproportionality. There's growing disparities over time by race ethnicity for diabetes. Now let's contrast that with the slide on the left-hand side. For this one, I'd like you to note that while most of the non-white racial ethnic groups are above the state average line, we have one group, which is the Asian Pacific Islanders, which is well below that line, and it's fairly flat over time. This is kind of balancing out a little bit of the overall disproportionality. I'd also like to point out that the red line, the continuous red line, represents non-Hispanic blacks. You can see that in the early part of the period, up until about 1999, obesity was increasing for this group, just as for all other groups. But starting in around 1999, obesity rates actually began to level off. This is a very unusual and kind of surprising finding. When we did a little bit more investigation and looked into a variety of factors that could influence that, we discovered that this is predominantly being driven by the decrease in obesity prevalence among African American males. And we have plans to do a little bit more digging to try to better understand what might be driving that trend. So next slide, please. That just points that out. Next slide. This is just a summary. I'm not really going to read through it because I think you can do that on your own. But I'd like to just close by thanking John for calling me, and I hope that I at least achieved 15 minutes and fun. And I'm done. Thank you.
Thank you, Marilyn. Now, I'm not sure if we have any questions. Do we have any questions, Betsy?
We do have one question.
Okay. And we have about a minute to answer it, so.
Okay. Is there any way to access trends in obesity, et cetera, for Washington's different immigrant groups, such as East African populations, Southeast Asian populations, and if so, how can we access that?
That is a wonderful question. I would love to be able to say yes, but unfortunately for all of Washington, we really are limited in the, even with a good sample size, we're limited in our ability to look at population subgroups. So the groups that I've shown you are the ones that we've been able to categorize, and I recognize that this is limited, particularly for areas where, you know, where we do have a lot of big diversity. I'm wondering if maybe when Ngozi speaks, she could perhaps address what she knows about is happening in Seattle, King County, because I believe that they do more oversamples for the purpose and may have more information about that.
Thank you again, Marilyn. We're going to move on to our next presenter. And our next presenter is Christy Kerrick-Hoff. Christy joined the staff of the Washington State Board of Health in October 2006 to serve as the Health Policy Advisor to the Governor's Interagency Council on Health Disparities. Christy served for 3 years in the Public Health Prevention Service at the Center for Disease Control. Christy, welcome and go ahead.
Thanks, Sabrina. Can everybody hear me okay?
Sound great.
Okay, thank you. I was thinking either nobody can hear me at all or that was all just everybody saying yes. Well, for my portion of this presentation today, I'm going to share some very general information about the Governor's Interagency Council on Health Disparities. I'm going to briefly discuss the process that the Council went through to arrive at its State Policy Action Plan, which is really the focus of my presentation, and then walk you through the plan and its policy recommendations, and then share where the Council is now and its next steps. Next slide. So because of the alarming disparities in health that Marilyn just discussed at a statewide level, the Council was created by the legislature back in 2006, and it was given some very specific and limited authority. The Council was charged with creating a state policy action plan to eliminate health disparities specifically by race, ethnicity, and gender. It was charged with identifying 5 health topics to focus on in its first action plan. It was charged with creating advisory committees to help with the creation of the recommendations that would go into the plan, and then once that first plan was done, to update the plan with a new version every other year. In addition to those responsibilities, the Council also has some general responsibilities to help coordinate health disparities and health equity activities, and it does this primarily through a federal grant that we have from the Office of Minority Health, but this presentation is really going to focus on the State Policy Action Plan. With respect to the action plan, I'd just like to point out that the Council's authority is simply advisory. It does not have the authority, the ability, or the resources to create or implement programmatic activities. Next slide, please. The Council's authorizing legislation was also pretty specific about its membership. The Council has a chair and 2 public members who are appointed by the Governor, and it also has representatives from 14 specifically mentioned agencies, boards, and commissions, and the secretary or the director of those agencies, boards, and commissions appoints the members to the Council. And what I'd like to highlight about the Council membership is really the diversity in the agencies that are represented. These are not all your traditional public health partners. And having agencies like the Office of Superintendent of Public Instruction and the Department of Early Learning enables the Council to look upstream at education as a determinant of health. Similarly, with, for instance, Department of Commerce at the table, the Council could consider topics like poverty or economic development. I mean, as Marilyn mentioned in her presentation, there's a real need to look upstream at those structural and intermediate determinants of health, and the interagency structure of the Council enables it to do so. Next slide, please. Here I just wanted to give you the Council's web address. It's healthequity.wa.gov. And at on the Council's website, you can find a copy and download a copy of the State Policy Action Plan to Eliminate Health Disparities. But that's a picture of it. So when you see it on the website, you can click on it and get your own copy. If you want a hard copy, you can let me know, and I'll be sure to get you one as well. Next slide, please. This next slide that is going to come up is one that always sort of makes me chuckle a little bit because it condenses about 3 years of the Council's work into a single slide. And I'm not going to go into the details, but the Council went through a very detailed two-phase prioritization process to arrive at its first priorities. As I mentioned earlier, the legislature asked the Council to consider a number of different health topics and social determinants of health and to prioritize them and pick 5 to focus on. Still looks like we're having trouble getting to that next slide. There it is. And as I said, it took several years to really get through this entire process, and it's well documented on our website. So if you want more information about the resources used to get us there and the steps we took, all of that you can find on the website. But in the end, the priorities that the Council chose were education. So that's looking at the academic achievement gap, healthcare workforce diversity, health insurance coverage, obesity, and diabetes. Next slide, please. As I mentioned before, the legislature also asked the Council to create advisory committees to help in the creation of its policy recommendations. And the advisory committees were given some specific responsibilities. We asked them to identify policy options to address inequities for the topic that it had. And I'll say that for the 5 health topics, we actually convened 4 committees. 1 committee looked at both obesity and diabetes. We asked the committees to review and assess the merits of each of the different policy options and to prioritize and deliver 3 to 4 recommendations to the Council for its consideration. And then maybe not most importantly, but definitely importantly, we asked the advisory committee members to act as ambassadors and advocates for the plan and the recommendations once they were released. And what you see on this slide are just some of the criteria that we asked advisory committee members to consider in coming up with the policy recommendations. And the one that I'll highlight for you is that we asked the committees to consider where systems changes could be made so that advances could not easily be removed or just defunded, but that they would be institutionalized. After the advisory committees came up with their recommendations, then the Council approved each of the committee recommendations and incorporated them into their state policy action plan. Next slide, please. So for this next series of slides, I'll quickly walk you through some of the Council's policy recommendations. I'll say that depending on the committee, some of the recommendations were very broad while others were quite detailed. And often, most of the recommendations had a lot of sort of sub-list of multiple sub-strategies. So I won't take the time to read through them all. But you'll see, for instance, with education, that what I've done is I've listed sort of the general focus areas of each of the recommendations. And each committee had 4 recommendations. So for education, the recommendations focused on equitable distribution of high-performing teachers and principals, effective family, community, and school partnerships, early childhood development programs, and then students' health and safety as a way to actually improve academic achievement. And the one that I want to highlight for you here is the first one there. And I'm highlighting it because it's an example of a systems change recommendation and one that would require no additional state funding by the legislature. It would simply restructure current funding to be more equitable. So currently in Washington State, teachers can receive annual stipends if they are nationally board certified. And then they can receive an additional stipend if they teach in a hard-to-staff school. So the Council proposed to reduce the annual stipend and redirect those funds to provide a larger stipend for teaching in schools that are identified as having large academic achievement gaps. So what this does is it incentivizes the placement of high-performing teachers in the schools where they are needed the most. Next slide. So for the Health Insurance Coverage Committee, this committee was actually meeting at the same time that health reform legislation was being drafted at the national level. And it turned out that many of the Council's recommendations were included within provisions of PPACA, the Patient Protection and Affordable Care Act. The Council still believes, however, that they remain relevant in helping Washington to implement the provisions and also to maybe encourage early adoption. What I'll highlight here is that the Health Insurance Committee spent a lot of time talking about how there are a lot of people, particularly people of color, who are eligible for public programs and are not enrolled, and that there really is a huge need to make the system simpler and more streamlined and easier to access. And that's really sort of the justification behind the first recommendation there. That recommendation actually has a lot of very specific language in it that you can find in the actual action plan about making access simpler, streamlining the system so that it's easier to access among people of color. Other recommendations of the Health Insurance Coverage Committee focused on access to comprehensive and culturally competent care, community-state partnerships in order to increase enrollment, and data collection requirements by race, ethnicity, and gender. And I'll also point out that this committee also took on the challenge of looking at recommendations around language access, and those recommendations were really about improving and expanding the current DSHS Interpreter Services Program, and also recognizing some of the problems with that program and also some of the vulnerability in that program in creating a long-term language access strategy. Next slide, please. The Healthcare Workforce Diversity Committee, its recommendations focused on not just workforce diversity, but also on cultural competence training for healthcare providers who are currently licensed. But the majority of its focus really was on diversifying the healthcare workforce. And the second bullet there is about setting targets for diverse enrollment and completion by healthcare education programs. And I'll talk about that one a little bit more in a second. The other focuses were on funding healthcare career exploration and preparation programs for students in kindergarten through 12, and also regular collection of data on the diversity of the healthcare workforce. This is a serious lack of data that we have in Washington State is on the diversity of our workforce data in general, but diversity in particular. And I'd like to highlight that second recommendation. That would require that post-secondary education institutions set targets to increase enrollment and completion of diverse students in healthcare education programs until the diversity reflects the population served. So it's really sort of a lofty recommendation there. And in order to ensure accountability, institutions would be required to report annually on progress to the Higher Education Coordinating Board. There's also language in the recommendation that if the legislature decided it wanted to move forward with establishing performance agreements with public higher education institutions, which it has considered in the past, that increased diversity could be a deliverable in those agreements. So those are the recommendations of the Workforce Diversity Committee. Next slide, please. And as I mentioned, we had one committee which took on both obesity and diabetes. And the obesity recommendations were pretty broad and focused on increasing access to healthy foods in underserved areas and requirements for schools regarding nutrition and physical activity. And these are the types of policy recommendations that we've seen to reduce obesity and diabetes in the general population. But this committee really thought that they would be effective in reducing disparities as well. Next slide, please. So for diabetes, what I'd like to highlight here is that the committee was really unbelievably surprised that the state was not providing any money to support diabetes prevention efforts. And they wanted to create this first recommendation here about having the state provide dedicated funding for a community grant program. They didn't think it was realistic. I don't think any of them thought that it would actually be implemented, but they really felt like it was so strongly and urgently needed that they were going to put it forward anyway. So that recommendation is really about providing state funding to get money into the communities for both diabetes prevention as well as diabetes management, which have been shown to be effective in communities of color through the REACH program. The other areas of focus were coverage of minimum standards of diabetes care, making sure that whenever there's a policy-making body making recommendations on obesity and diabetes issues, that there's an endocrinologist appointed to those, and then also trying to increase certified diabetes educators and programs in communities of color. Next slide, please. So the plan was released, and it was submitted to the governor and the legislature in June 2010. And at that time, we made a lot of offers to legislators, to the governor's office, to come answer questions, to come give work sessions, to provide briefings, whatever they wanted, we were willing to do for them, and we did not get taken up on any of our offers, unfortunately. We posted the action plan to the website, and we sent the link out very widely. It went out to a number of local, statewide, and national distribution lists. We spent a lot of time creating what I thought was a pretty good press release that might be attractive and actually interesting. And unfortunately, it really wasn't picked up either. I think there was another press release that came out from the Department of Health on the same day, and I can't remember what it was, but it was a good one. And so the press really picked up on that story. Fortunately, with our grant from the Office of Minority Health, we were able to print about 2,000 reports, and we've gotten those out. I think I only have one box left, so there's 1,500 reports floating around, and we really tried to get those in the hands of local organizations, groups that had similar priorities, groups that had the ability to advocate on behalf of the recommendations and who might be able to use the Council's recommendation to help further their goals. And then we shared the information at conferences and meetings. So we've really tried hard to get these recommendations out there. And I have to say that with the focus on the budget and also with the loss of some key legislators, we just haven't seen much or any movement of these recommendations to date. Next slide, please. So in terms of next steps for the Council, we will continue to make sure that information about this particular plan and these recommendations stays out there. It's not as though, you know, if they're not implemented this session, then they are no longer relevant. The Council definitely doesn't believe that, and we'll continue to try to get these recommendations in the hands of those that would find them interesting and might want to move them forward. And as directed by the legislature, we are also in the process of moving forward with the next version of it. And the first step is to identify what the priorities are going to be. I will tell you that at the Council's next meeting in May, it anticipates that it will select its next priorities. Right now it's interested in the broad topics of maternal child health, environmental exposures and hazards, poverty, and behavioral health, including adverse childhood events. And so at the main meeting, we'll have a lot of space on the agenda for Council members to talk about those issues and maybe fine-tune and select some more specific priorities from within those categories. And the next slide has my contact information so that you know how to reach me. And that's it for my presentation, Sabrina.
Hey, Christy, do we have any questions for Christy? And we're getting short on time, so we want to make sure we have time for the other presenters. If we don't get to your question, we can always do them later.
We do have one.
You can contact the presenters offline. Betsy, any questions?
We do have one question. Would you like to do it now or wait until later?
Yes, go ahead.
Okay, this question is from John. Undoubtedly, funding will be an issue. Regarding the shortfall that is forecast for Washington State this year and for the next biennium, what contingency does the committee have to implement its recommendations?
John, I hate to say that there isn't really a contingency. As I mentioned before, the Council's authority is very limited. So when it was given the responsibility of coming up with basically policy recommendations that go to the governor and the legislature, but we don't have any authority to implement them. So, you know, we couldn't come up with like a strategic plan that said we're going to do this work. We just, I think most importantly, we don't have resources to do it, but also we really don't even have the authority to do so. It's a strictly advisory committee. So, you know, the other thing I would like to, you know, sort of talk about and talk with others about, especially our Council members, is, you know, how can we use the agencies that are represented on the Council maybe a little bit more efficiently so that we can ensure that that maybe some of the work can still be implemented even if it's not specifically funded or directed by the legislature. So that's one thing that's sort of in my head, and I'm always willing to hear from others about their ideas for how we can maybe be more effective given the barriers and limitations in our authority.
Thank you again, Christy. Our next presenter is Dr. Joel McCullough. He is a Public Health Director and Health Officer for Spokane Regional Health District. Thank you, Dr. McCullough. Please go ahead.
Good afternoon. My name is Joel McCullough. As mentioned, I'm the Health Officer at the Spokane Regional Health District, and I was asked to present on some of the activities we're doing here in Spokane around the area of social determinants of health. Next slide. I'll be covering 4 activities in this presentation. Most of the time will be spent describing a new pilot project here at the Health District called Neighborhoods Matter. Next, I will describe Priority Spokane, which is an effort to address social determinants of health, but it's organized outside of the public health system. But public health is an important participant. And I'll be mentioning how the social determinants of health is being addressed in our current strategic plan. And finally, I'll mention the health inequities report that we're planning to release later this year. Next slide, please. In the fall of last year, the Health District launched this new program called Neighborhoods Matter. And it was an effort to have a different approach to addressing MCH issues. The program was conceived of by Elaine Connolly, the Division Director of the Community and Family Services Division. And it was an effort to look at MCH and interventions in a different way as opposed to the traditional one-on-one approach. Next slide, please. The concept was that Neighborhood Matters would be a neighborhood-based activity, operating in a single neighborhood at a time. And more than likely, the neighborhood would be low income and have health disparities in maternal child health areas. And Neighborhoods Matter was an effort to address these health disparities in MCH. Next slide, please. What we're trying to do with Neighborhoods Matter is to increase the capacity of the neighborhoods in broad terms to address some of the root causes of these health issues, which are linked to the social determinants of health. We're also trying to improve the social connectivity among the neighborhood residents, which we know are important social determinants as well. And ultimately, we want to create a process that is sustainable. And if this model is successful, we hope to go to other neighborhoods and have a similar type of model as well. Next slide, please. When we talk about this Neighborhoods Matter program, one of the first questions we get is how is it funded and how much does it cost? And as you can see from the slide, it's a fairly expensive program, costing approximately $430,000 a year. And most of the funding is coming from local dollars. And we've decided to give this program a 3 years to pilot as a pilot to see how effective it is in addressing some of the social determinants of health and working with the neighborhood. Next slide, please. As I mentioned earlier, Spokane, the Neighborhoods Matter is a neighborhood-based program, and there are 38 different neighborhoods here in Spokane. And this map shows the different neighborhoods here. The smaller central area is the area closer to downtown. But we did have to have a process for selecting which neighborhood would be our pilot neighborhood. Next slide, please. Because the program is focused on maternal child issues, key indicators regarding this effort would be required. So you can see here some of the indicators that we thought were important to measure when selecting a neighborhood, and these indicators were used in our selection process. Next slide, please. This slide shows a composite of our selection process. The selection process took many months, and a lot of different efforts were involved, but this slide kind of shows you basically what happened. Initially, we had all the neighborhoods in a database, and we scored them based on the MCH factors or criteria that I just mentioned. And the neighborhoods that were below the county average were eliminated because they were not as in need of services. The next cut was looking at the desired assets within a neighborhood, because you just don't need, but you also have there's also the necessity of assets. So some of the assets that we looked at were the presence of a community center, presence of organizations within the neighborhood that would be supportive, and having engaged citizenry. And after this process, we determined that there were top 3 neighborhoods: East Central, Greater Hilliard, and West Central. And through a more involved process, which I'll talk about next, we did finally come up with a selected neighborhood. Next slide, please. This slide shows some of the factors that we looked at when we made our final decision about the neighborhood. 40% of the factors included demographic and health factors. And you can see at the top the weighting that was involved for the different factors. Next slide, please. About 60% of the application was judged from the written application that the neighborhood presented to the health district. And you can also see the weighting that was involved here as well. So the protective factors, stabilizing factors, willingness to participate, and resident involvement were weighed in our decision to select a neighborhood. Next slide, please. So, as I mentioned earlier, each of the 3 neighborhoods wrote a written proposal to be selected as a pilot neighborhood, and we accepted only 1 application from each of the neighborhoods, and in the end, the advisory board members reviewed all the information from the 3 neighborhoods and finally did make a selection, and that selection was the neighborhood of East Central. In Spokane, East Central is one of the more diverse neighborhoods in a not so diverse county, and has a population of approximately 1,200 people. Next slide, please. This slide shows the general structure of Neighborhoods Matter, with the Neighborhood Governance Council on top, which are made up of the community members. Also, you'll see the Neighborhoods Matter staff, which is depicted as SRHD staff, which interacts with the advisory board. And at the bottom is the steering committee, which is made up of executive team members. Next slide, please. Well, the key to the success of the Neighborhoods Matter program will be what happens in the neighborhood, and what's governing that would be the Neighborhood Governance Council. And these are volunteers who agreed to serve on the Governance Council and agreed to work on some of the MCH issues that will be identified as priorities. Next slide, please. Another important component of Neighborhoods Matters is the advisory board. Also, advisory board is made up of individuals who are not in public health as well. It's made up of a diverse group of individuals, including political people, people who work in nonprofits, academia, human services, education, mental health, and medical. Next slide, please. And then there's the Neighborhood Matters staff, which is supervised by a CFS division director. And the bulk of the funding for the program goes to staff salaries and benefits. Next slide, please. This slide shows some of the way we went about prioritizing the efforts in the neighborhood. Before the neighborhood was selected, we did have key leader interviews, which helped us determine which factors are important in our community, which areas that we need to be considered working on, what are the problems and what are the assets, basically. And after the neighborhood was selected, we did do focus groups. We held a community luncheon and held asset interviews, all to help identify neighborhood assets and concerns. Because of the large number of concerns in a neighborhood, the Governance Council helped, along with SRHD staff, help prioritize the concerns, and work teams were then developed to address the specific concerns, and that will eventually lead to action. Next slide, please. In terms of where we are now, we have developed two main work teams, and the first work team is involved in nutrition and physical activity. And within this category, the team is working on a community kitchen, community garden, and an urban harvest. And the second work team is the MCH work team, and those current activities include parenting classes, a community cafe, and an effort to address maternal smoking. Next slide, please. I'm going to change gears a little bit and talk about another effort that's going on here in Spokane, and it's called Priority Spokane. And this is the effort that is taking place outside of public health system, but public health is an important participant. Next slide. Priority Spokane came about in 2004, and it's from the Eastern Washington University Institute for Policy and Economic Analysis. And this was an effort to develop a set of indicators that are important to Spokane. The Community Indicators website went live in 2006, and after the Community Indicator site went live, some of the members of the process, local government, business leaders, etc., wanted to use this site for more community action. And there was a vision to prioritize community action that will lead to measurable improvement. And Priority Spokane was then launched. Next slide, please. Priority Spokane is divided into different categories. There's the steering committee organizations. There's also the Spokane area research on education and reform and funding partners. And also from this slide, I wanted to point out that the health district was involved in the research and education reform, and also on the steering committee. Next slide, please. Much of the work to date has been identifying community priorities, and there's been a very involved process over the last several years to determine what the priorities are. And if you're interested in more details, I invite you to visit the Priority Spokane website. Next slide. Well, the steering committee engaged in more than 120 citizens in an effort to identify community priorities. There are 5 task forces that were formed, and the task force included economic vitality, health, education, environment, and community safety. And using these criteria, each task force was charged with identifying community priorities using the Community Indicators Initiative, as well as data from the health district's Spokane counts. And as a result of the work of the task force, these current priorities emerged, improving K-12 educational attainment, etc. Next slide, please. After some work among the steering committee and task force members, educational attainment and dropout prevention became the leading effort that Priority Spokane is focusing on, mainly because the graduation rate and dropout prevention is tied to other important indicators in our community as well, such as unemployment, poverty, criminal justice, etc. And in the end, it's hoped that Priority Spokane will be a catalyzing force within the community. And over the next 5 years, it's intended that Priority Spokane will make a lasting difference in the lives of our community here in Spokane. And this slide shows the steering committee for Priority Spokane. And I don't know if all you know all the individuals, but many of you in public health will recognize Lindy Ty and Tony Smith as members of the Priority Spokane Steering Committee. Next slide, please. Changing gears again, I'll talk about efforts here at the Health District in which we've integrated social determinants of health into our strategic plan. Next slide, please. In the spring of 2009, the Health District developed its latest strategic plan, and as part of that, we did put addressing social determinants of health as an important component of that plan. And we've been working since then to determine how best the agency and our community can work on the social determinants of health. Since inception, I think most of our time has been spent on educating our members because this is such a large topic, and there's many different components and different views of this area. Education of the members of the committee has been one of the primary activities thus far. We've also tried to develop a common language that we can all use. As you may know, this field has different terms and terminology that is not always consistent, and one of the efforts of our group is to make sure, at least us, the group and as an agency, when we use the same terms, we mean the same thing. Another area that we're working on is that there is an education committee as part of the strategic plan goal, and the education committee is developing a curriculum for the health district on social determinants of health. There have been several achievements of the goal, but I'll point out a couple. Last spring, the health district had an agency-wide presentation on social determinants of health, and it was held, and the presentation was given by Dr. David Williams from Harvard University, who's obviously a national figure in this area, and his presentation was well received by the staff. Another achievement is that we are supporting a report on health equities that's being currently worked on by one of our epidemiologists in the Health District, Adrian Dominguez. Next slide. About the Health Inequities Report, the the report will stress the importance of health inequities to public health. We're certainly aware that an awareness of the problems is insufficient to making changes, but it is our hope and belief that with local data, the issues regarding social determinants of health will be more compelling to our local audience, and changes will likely follow after that. The report isn't finalized yet. There's many areas of analysis that will be involved, and the final data hasn't been determined at this point, but an example of some of the analysis that will be coming from the report will be looking at infant mortality by maternal age, life expectancy by income, life expectancy by race, and chronic disease by income. The timeline for the release of this report is May of this year, and we look forward to sharing it with you. But that's the end of my presentation. Most of our work is works in progress, and we hope we will be successful in most of our efforts. Thank you.
Thank you, Dr. McCullough. We have time for one question. Betsy, if you have questions, that'll be great.
Okay, I have two actually. The first is, what is Spokane doing to evaluate and document the impact of Neighborhoods Matter?
The program staff are developing specific evaluation criteria for each of the activities. So given that there are a number of activities, each activity will be evaluated separately. And once we kind of figure out the impact of the different activities, we'll make a decision about the success of the program.
Thank you, Betsy. If we can defer the last question to the end to give our last presenter a chance to go.
Okay.
And if there's time, we'll ask that last question after our next presenter, which is Dr. Ngozi Oru. She is currently the Director of the Environmental Health Services Division for the Public Health, Seattle-King County. She is also the co-chair of the county's inter-branch team, which is leading the equity and social justice work. Go ahead and welcome Dr. Oru.
Thank you, Sabrina. I am going to try and fly through this, and unfortunately, I don't have my contact information on these slides, so I'm hoping that the organizers will put it on when you release this. So if people have questions or need information and want to get in touch with me, you can do that. So
we'll do that, Doctor. Sure.
Okay. So what I'm going to talk to you about is where this all came from, why foundational issues, and then the ordinance itself. So where did equity and social justice come from? In 2006, we were invited, King County was invited into a national effort called Place Matters. Place Matters is a project that has been put on by the Health Policy Institute of the, now I'm going to draw a blank. Anyway, so this is a national project that has invited about 26 jurisdictions from across the county to become part of looking at the experience of people of color across the nation as far as health is concerned, and to look at those factors that are embedded in our society that cause people of color to have differential outcomes. And so we've been part of that, and this work, Equity and Social Justice in King County, is the project that we're doing for Place Matters. In addition to the Place Matters invitation and project, that same year, I think the end of that year, the Health Policy Institute released a report that they called the Dellums Report. It was chaired by Mayor Dellums of Oakland at that time. And it looked at the health experience of young men of color, what was affecting their life experiences. And when our then executive saw that report, he was so impressed with it, he asked us here in King County, to replicate that report for King County. And when we did, it showed the same kinds of trends that were seen in the national report. And then as a result of these two things, then Executive Sims launched the Equity and Social Justice Initiative here in King County in 2008. The next question, which is why? Why focus on, next slide, please. I'm going to forget to do that. Why focus on equity and social justice in King County? Next, okay. Reason, King County has one of the most diverse populations, if not the most diverse here, at least in Washington State. In 2009, New York Times published that we have the Tukwila School District is the most diverse school district in the country. And next slide. Okay, I think you have to keep clicking it so it will show the rest of it. Anyway, those are the numbers. I'm not going to read them out so that I can get through the information. But 2009, we had the most diverse school district in the country. 2010 census also showed that we had the most diverse zip code in the country. Next slide. More of why we're focusing on this, the good, is because King County, we have in King County, we have indicators of quality of life and social determinants of health is generally higher relative to other jurisdictions in the country. The bad is that in some cases, I prefer the word inequities, but the inequities in King County in these indicators are wider than in other jurisdictions. And then the ugly is that in some cases, the disparities in equities are increasing. Next slide. Oh, so this is the slide of the floor of King County Courthouse, the lobby, which shows a picture of the March on Washington, Martin Luther King. Next slide. So the foundations, what are the foundations that ground this work in King County? In 1986, there was a proposal to change the namesake of King County from William Devane King to Dr. Martin Luther King, Jr. In 2005, Washington State legally changed the county's namesake to Martin Luther King, Jr. And in 2007, King County adopted a new logo in honor of Dr. Martin Luther King, Jr. Next slide. In 2007 also, King County, through its health department, Public Health Seattle, King County, adopted a framework for the health of the public. And in that, the mission says that we identify and promote the conditions under which all people, and that's underlying, all people can achieve optimal health. The goal is for King County to employ strategies, policies, and interventions to reduce health disparities. That's one of the goals. And there were 4 guiding principles to get us to these goals and this, as we do this mission. And one of them is that our work is to be driven by social justice. Next slide. So in 2008, the Equity and Social Justice Initiative was launched. As I said before, it is a project that we're doing for the Place Matters movement that we're part of, the national movement. The initiative was launched in 2008 by then Executive Sims. And at that time, the work was pretty much confined to the executive department. So all the departments that were under the executive were charged to begin considering equity and social justice in the work that we were doing. I believe that my colleagues, Matthias Valenzuela and Sandy Siski, did a presentation on the initiative at the last conference. So what I'm talking about now is kind of what has happened since. And this is kind of the background to it. Next slide, please. More on foundations. In 2009, as a result of a council ordinance, which directed the county to produce a county-wide strategic plan, the work on planning, developing that plan began. Next slide. What was really lucky for this work in King County was that by the time the development of the strategic plan started, the work on equity and social justice had matured to the point where what we needed was, what we're looking for was, how do we begin to institutionalize? So we had an initiative. How do we begin to institutionalize the work so that it wasn't something that was going to be here today and gone tomorrow, or something that would be subject to whomever was in power at the time, and whether or not they were inclined to do work this way. So it came that the development of the strategic plan, the people who were working on the Equity and Social Justice Initiative became very much involved in the development, including who got to really put forward input into the plan. Because part of what the initiative was about was community engagement. How do we become more engaged and better engaged with community as we developed our policies and as we implemented them? So this was a really good time to test what we had taken on to do with community engagement. So it was a very broad engagement of community in developing the plan. The strategic plan was adopted in 2010, last year, 2010, early last year. And it's a county-wide plan, and it's a 5-year plan that says we're going to be working together. We're working together for one King County. Equity and social justice principles very much embedded throughout the plan. The vision, as it talks about there, it really acknowledges the diversity in our county, the fact that it is a dynamic community with healthy economy and environment where all people, again, underlined, and businesses have the opportunity to thrive. Guiding principles, we were very lucky to get this in there as one of the guiding principles, and it is the fair and just principle. That we serve all residents of King County by promoting fairness and opportunity and eliminating inequities. I mean, this was big. So, as I said, it was really lucky that we were at this. Thank you. Next slide. We were at this point of strategic plan development because it became the vehicle. It became the vehicle to really institutionalize what we were doing with equity and social justice. So this guiding principle became the ordinance that the Equity and Social Justice Ordinance was a way to implement the fair and just principle in the strategic plan. So this is the ordinance, and I'm not going to read through it because it will take up time. So you can read it at your leisure. Next slide, please. So when we talk about equity, we say equity and social justice. What is this equity that we talk about? What is it that we're trying to do with the ordinance? What is it that we're trying to do with this work? And the definition we have is that it is a system of fairness where all people have full and equal access to opportunities that enable them to attain their full potential. And next slide. What influences equity? As you have heard already, the social and political factors plus economic factors plus geographic and environmental factors become the determinants of equity. And in order to impact equity, we must look beyond the individual. That's what we're trying, the work that we're trying to do is we need to look beyond the individual and actually go to the structural and social factors that shape the decisions that individuals are able to make. And this slide shows those areas, the determinants of equity that we are working on here in the county. These are the determinants of equity that we have chosen to work on. And what we're trying to do, we have a stream, actually a visual that depicts how we're working on this. What we're trying to do is push as much upstream as possible to look at those fundamental foundational issues that create equity. Next slide. So what are the equity and social justice foundational practices? What we're working on to raise and sustain equity and social justice visibility, focus on the determinants of equity, consider equity and social justice in all decision-making in the county, foster an organization that promotes opportunity, collaborate, 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 and then build capacity. Really build capacity to engage all communities. Next slide. Next slide. Okay, so the actions that we're doing, we have an inter-branch team that is responsible. It used to be an interdepartmental team. Now we have graduated to inter-branch team because this work is being done across the county now. All elected parts of the government, the executive, the council, the courts, the PAO, the assessor, elections, everybody is working on this now. We integrate the actions that we have been mandated to carry out in this interbranch team to integrate equity and social justice practices into the county's plans, management systems, and budgets, develop equity impact review tools, develop guidelines for community engagement, that's one that we just finished, develop employment and business practices that support equity. We have annual work plans and commitments that each branch and each department does or to do, and then we're to report annually on the measures and the results. I just want to share some of the things that have been key to success as it is right now, that where we are. What has helped us is that we've had political will at the top. Both county executives, Executive Sims when he was here and County Executive Dow Constantine have totally embraced this idea as the way to do business. We have other elected officials in the county who have come on board and have been on board, department directors through the cabinet. The executive office and public health are facilitating this work. So I am co-chairing the interbranch team with a colleague, Carrie Sheehat, from the executive's office. And like I said, all departments and all branches are participating. I want to say a word about framing. We're all health departments, and I have been asked this question over and over again. Why are you not talking about health equity? We made an intentional decision to use equity as opposed to health equity because of the idea that we're talking about social determinants of health. And social determinants of health, really when you look at it, it shows you how health is driven by so many other factors that are outside of the health department. So we chose equity so that it would be easier to work with our colleagues in transportation, in parks, in economic development, and they could see themselves owning this work as opposed to if they thought that this was health equity, it should be done by the health department. So that was a conscious decision we made to talk about equity and social justice as opposed to health equity. I think I'm running out of time, but as a result, we find that there really is great return on investment find that we're able to, it's a little bit more efficient and better government when we all own this as a society, and really the social determinants of health, everyone sees their part in it. And then it creates competition and spurs excellence. I mean, the commitment that different departments and branches are putting forth, it's like, okay, what are we going to do this year that really is broad? We find departments are doing commitments that after they have developed it within their department, we can raise it up to the county level. We have 2 now that have been adopted. We have a translation policy that was worked on in the health department, and that by executive order now is countywide. Everybody uses it. And we find that really this way of framing supports the goal of the county strategic plan. And the last slide talks about resources. Those are the website where you can find the work that we're doing on equity and social justice, the county strategic plan, and Communities Count, which is one of the data sources that really informs a lot of the work that we're doing, that documents the rates of inequity here in the county. And then my contact would be put on, so if you need information or have more questions after this, please don't hesitate.
Thank you so much. We will add your contact information. I think, Betsy, we have time for one more. We have a time for a question. And also on the screen are national resources. So, Betsy, if you maybe give us one question if we have any.
We do have a question that just came in. Given the ESJ implications of recent police actions, how active is the health department in addressing violence and historical trauma within critical public health safety net institutions such as police, fire, and parks? I'm thinking particularly about the long-term effects on chronic disease disparities such as asthma, which is known to be affected by violence.
Yes, very good question. One of the things that kind of distinguishes our work is we have things that the county has direct influence on, and things that we can influence by partnership. And so the issue of violence and police activity is one of those where we can influence by partnership. And not one of the determinants that you did not see on that slide is that law and justice is one of the areas too that is part of our determinants of health. And so we are working the courts and the justice component of county government very much on board with what we're doing. And we're hoping that they just came on with the passage of the ordinance, and we're all going through trying to bring the new members on board. But we're hoping and looking forward to having commitments out of those areas that can address these issues.
Thank you so much again, Dr. Olaru. And we want to again thank all of our presenters for presenting this great, wonderful information. I want to remind everyone out there that this presentation is being recorded and will be available on the WSPHA website. And we also want to hope you join us for our April webinar as 3 professional health communicators discuss the trends, success, and challenges they are facing in telling the public health story. And that's going to be on April the 7th, 12 p.m. to 1:30. So look for that, and please sign up. And thanks so much for your participation and listening. And if you're not a member of WSPH, please join today. Thanks again, everyone.